Well, tonight's presentation is entitled Strategies for Treating Alcohol Use Disorders, and our presenter is the very distinguished Mr. Tommy Richardson. Dr. Richardson is a family physician and a certified addiction specialist who has over 20 years of experience in identifying, diagnosing, and treating chemical dependence and psychiatric illnesses. He has organized and implemented healthcare delivery systems that have enhanced the lives of thousands of citizens. He takes a holistic approach to delivering healthcare through individual and family counseling. He treats addictive, psychiatric, and medical disorders. Application for CME credit has been filed with the American Academy of Family Physicians and has been approved for a maximum of 1 prescribed credit hours. Well, tonight's presentation will be divided into 2 sections with a brief or break for questions in between and also an extended question and answer session at the end. However, questions and or comments can be submitted throughout the presentation. If you notice in the left-hand corner of your screen, there's a Q&A box. Feel free to type in your questions and or comments and click submit, and we will address them at the appointed time. So with all of that said, ladies and gentlemen, let's welcome Mr. Tommy Richardson.
Thank you very much. Good evening to everyone. Today we're going to talk about alcohol. Some of my slides have reference to other addictions, but since this is on alcohol, some of those will be skipped and I will concentrate primarily on alcohol. When we think about addiction, there are 3 C's and denial. The C's usually relate to loss of control, compulsive use, and continued use in spite of negative consequences. Alcohol drug problems are the second most common mental disorder. It involves 8 to 10% of all adults. Alcoholism is the 3rd leading cause of death in the USA behind cancer and heart disease. You might have heard people talk about denial a lot when they are dealing with addictions. But in my experience, I think it is more of a lack of insight that the patients have. A lot of patients will come and they say, I have a problem with drinking. They just don't have insight into the severity of the drinking. And as you can see in this cartoon here, he's asking a question, what will you be working on this spring training? And I got that in there because we used to work with a lot of athletes, and these guys work on their urine samples, trying to get a negative urine sample most of the time. The prevalence of alcohol use, and this is data from the NIAAA. The number of people with any alcohol disorder is about 17.6 million, which is 8.5% of the population. Alcohol abuse accounts for another 9.7 million, and alcohol dependence is 7.9 million. So if you put all those together, and sometimes it's very difficult to distinguish between the 2 conditions, alcohol abuse and alcohol dependence, but hopefully I'll be able to help you guys with that if you have any questions. And once again, we look at the prevalence rates of alcohol. It's approximately 10%, with drugs, illicit and prescription drugs, about 10%, and psychiatric disorders, as you can see, and this is all of the psychiatric disorders, is only about 7%. So you can see addiction outweighs mental health disorders, which is huge. And this is another cartoon that I love. Every time I look at this, I sort of chuckle because you can see the sizes of these glasses, and the guy is saying, let's have one more and then we'll go. It's always one more. Now, this is a definition of the standard drink. A standard drink equals approximately 14 grams of ethanol, and you can find this in 12 ounces of beer, regular beer, or wine cooler, which has 5% alcohol, 5 ounces of table wine, which has 12% of alcohol, and 1.5 ounces of hard liquor of an 80 proof drink. This contains 40% alcohol. The average person metabolizes approximately 1 standard drink per hour. And what that translates into, if a person's blood alcohol level is 0.3, in 1 hour it will decrease by 0.05 milligrams percent. Alcohol and drug problems accounts for greater than 75% of liver cirrhosis, greater than 50% of all suicides, greater than 30% of all emergency room visits, greater than 30% of all hospital admissions, more than 25% of fatal car wrecks, and greater than 50% of all inmates that are incarcerated in our country. If you look at the societal costs of alcohol abuse, the total cost is estimated at approximately $184.6 billion. And if you would look at the costs that are most prevalent, and it is the loss of earnings due to alcohol-related illnesses, loss of future earnings due to premature deaths from alcohol, and the rest of the budget is minuscule compared to those issues. Now, this is a graph to show the undertreatment of alcohol use disorders. As you can see that there are approximately 17.6 million people. Out of those, 7.8 are alcohol dependent. Only about 2.2 seek treatment, and only 0.1% are treated with medication. So there's a huge discrepancy between the people who have the disease and the ones who get treated. The history of addiction. Benjamin Rush defined alcoholism back in 1795. And it was in 1965 when the AMA defined alcoholism as a disease. And in 1980, the DSM-3 described addiction as a biopsychosocial model of disease. And as you can see, in 1985, only cross addictions became on the forefront. And what cross addiction refers to is that if a person is addicted to cocaine, for instance, and they stop using cocaine, they are likely to become addicted to alcohol if they substitute the use of alcohol for another addiction. And there's also an entity called process addictions, and these include food addiction, sex addiction, shopaholics, workaholics, etc. And we can talk about that more if you guys have any questions about that. And this is nicotine. I know we're not talking about nicotine, but I'd like to point this out. Approximately 3 jumbo jets crash into the earth daily with everybody dying represents the number of lives each day that we lose to tobacco. So nicotine and alcohol usually go together, so it's a great problem. It is a biopsychosocial multifactorial disease, alcohol and other drugs. I want to make a distinction between what this slide says. This slide says alcohol and drug dependence, but it's actually alcohol and other drugs because alcohol is the #1 drug in our society. If you look at other chronic medical diseases that you guys are probably treating on a day-to-day basis, we'll take, for instance, asthma, diabetes, hypertension, and you compare the heritability estimates, the compliance issues, and the relapse rates to these of these diseases with alcohol and other drugs, you will see. With asthma, approximately 0.35 to 0.75. There's a heritability of 0.35 to 0.7. With diabetes type 1, the heritability is 0.7 to 0.95. With type 2 is 0.3 to 0.5. And these are all males because most of the data we have are related to males. Hypertension, the heritability is about 0.25 to 0.5. Alcohol dependence, as you can see, is 0.55 to 0.65. And then drug dependence is 0.35 to 0.5. And these all are referencing the males. If you look at other chronic medical diseases and the compliance issues, if we take hypertension, for instance, the compliance with medication regimen in hypertension is less than 30%. The compliance with diet is less than 30%. Retreated in 12 months by either the ER, primary care physician, or admission to the hospitals is about 50 to 60%. If we look at asthma in the adults, the compliance with medication is only about 30%. Retreated in 12 months is about 60 to 80%. 50% of recurrence due to lack of compliance. And we take a look at insulin-dependent diabetes. The compliance with medication regimen is about less than 50%. Diet and foot care is less than 30%. Retreated in 12 months by either the ER, hospital admission, or primary care physicians, that total about 30 to 50%. The comparison of the relapse rates between drug addiction and other chronic illnesses, as you can see, drug addiction, which will include alcohol, 40 to 60%. Type 1 diabetes, the relapse rate is 30 to 50%. Hypertension is 50 to 70%, and with asthma is 50 to 70%. So you can see the relapse rate to addiction is less than hypertension, and it's also less than asthma. Because a lot of people think about, especially physicians, think that alcohol dependence is not treatable. And I hope that that previous slide sort of showed you that it is. The final common pathway to addiction. Genetics is one piece of the pie. One of the major contributors is childhood trauma, stress, availability of the drugs or alcohol, and psychiatric comorbidities. I just want to say that alcohol dependence and other drug dependencies are brain diseases that involve the neurotransmitter systems in the brain, but they are precipitated by stress. So always keep that in mind when you're seeing a patient with any type of addiction. The neurobiology of addiction, the brain, we're going to talk about the brain, the neurochemistry, and neuroadaptation. If you look at the brain, this is a sagittal section here, and it shows the nucleus accumbens, which is in the area of the medial forebrain. And this is where most of the addiction takes place. It's in the hypothalamic area, involving the ventral tegmental area and the prefrontal cortex, is also involved. The hypothalamic drives, as you know, there are 6 basic primitive drives: hunger, thirst, sex, flight or fight, and pain. And addiction becomes a 6th basic primitive drive. And that drive is stronger than pain, the flight or fight system, sex, thirst, and hunger. And I always add air, because the people that it kills is even stronger than air. And if you look at the, this is a scan showing the memory of drugs. If you look at the front of the brain, this is a person who is watching a nature video. And as you can see, the amygdala, which encompasses most of our memory, is not lit up. But if it's a cocaine addict and you show them a cocaine video, and the same would happen with alcohol, you see that the amygdala is activated. And this is a very significant aspect of addiction and how strong it is. You know, one of the major neurotransmitters is dopamine. And this is just a slide showing a presynaptic neuron and the synapse and the postsynaptic neuron with the dopamine receptor. And one of the ways that addiction affects the brain is that it washes out the dopamine, the serotonin, and norepinephrine in the synapse. This is a slide showing the pathophysiology of the potential for relapse. And if you look at the presynaptic neuron, where glutamate is the main neurotransmitter that is shown, and in the postsynaptic, you see the NMDA receptor. During relapse for alcohol specifically, the glutamate is elevated, and that's what precipitates the withdrawal symptoms, i.e. the sweating, the nausea, the vomiting, the shakes, as well as the severe cravings for alcohol. And this shows the features of alcohol dependence. If you look at the first slide on the left, the upper left, it shows the major inhibitory neurotransmitter, which is GABA, gamma aminobutyric acid, and the excitation neurotransmitter, which is glutamate. And if you look in the normal state, the brain is balanced. So there's a normal amount of glutamate and GABA. If you look at the second slide in the middle, this is acute alcohol intake. When you drink alcohol, you get a surge of GABA. So it's tipped in the favor of GABA. You get a surge, and that's what decreases the anxiety as well as causes a calmness. And if you look at the third slide over, it shows you the tolerance. When tolerance has developed, once again, you get what is called neuroadaptation, and the brain now is tolerant to alcohol. So it takes a certain amount of alcohol to keep the brain balanced. And the left lower slide shows you what happens in acute withdrawal. The pendulum swings to the glutamate, and that's where the symptoms come in, and that's why we have to detox these people with various drugs to bring the brain back into balance and prevent DTs or withdrawal seizures. And then what we call the post-acute withdrawal symptoms happen, and this can happen months after a person has stopped drinking. As you can see, the extended symptoms are still there. They have difficulty with sleep, mood disturbances, and etc. So that's when medications come into play to bring the brain back into balance. Alcohol and drugs flood the system. The receptors are downregulated, and then you develop what is called neuroadaptation. Tolerance develops. With abstinence comes the withdrawal. Residual post-acute withdrawal is once a person has stopped drinking and has gone to AA but have not had with any treatment, they will have a long period of residual post-acute withdrawal. And these can include insomnia, dysphoria, irritability, and anxiety. Now I'm going to stop at this point prior to getting into treatment to see whether or not there are any questions that we can answer at this point in the presentation.
So if any of our participants have any question, then please type them in the Q&A box below and click submit. Okay, Dr. Richardson, I don't see any as of yet, so
Okay.
we'll just go on.
We'll move into treatment. Treatment is broken down into behavioral interventions, detoxification and evaluation, cognitive insight, emotional understanding, and transformational experiences. And we start obviously with detoxification and evaluation. When they come into the hospital, but what's so critical, especially for primary care physicians, is to be able to triage and do screenings for alcohol problems in your office when you see patients for medical conditions.
Dr. Richardson, we do have a question a little bit along those lines. I'm not sure if you could see that in your box, but Michael asks, how do you communicate the nature of addiction to a potential patient for dependence and or abuse?
Okay. How to communicate the nature of addiction to a potential patient for dependence versus abuse. And I hope that you're meaning, how do you distinguish between abuse and dependence? The way we do it in the addiction field, a person may drink a lot of alcohol as an abuser. Indeed, they might drink more than someone who is dependent. But the way you can distinguish is that a person who has an abuse issue, if they run into some problem, like say for instance, they get their first DUI, they can stop drinking or they can significantly moderate their drinking. Whereas a person who has the dependence will continue to drink, they will lose control, their drinking will be compulsive, and they will continue to drink in spite of negative consequences. And I hope that answers the question.
Yeah, I think he meant, well, how do you, say you recognize it in a client, in a patient, how do you sit them down and have the conversation? I'm concerned that you are addicted, that you do have a problem. How do you bring that up? How do you
Okay.
have that conversation?
Okay. Yeah, that puts a little bit more light on it. What if you do an exam? For instance, you want to give them a CAGE. We use a CAGE, C-A-G-E, which is about 4 questions. And you can ask the patient, have you ever had anyone to complain about your drinking? Have you felt that you needed to cut down on drinking? And have you ever needed alcohol as an eye-opener? So those kinds of questions are what the primary care physician can utilize, and that's what we always recommend. So if someone would fill out the survey and they answer yes to any of those 4 questions, then I think you would sit down and just say that usually people who don't have problems with alcohol will not answer yes or positive to any of these questions. And I think you cannot do that or have that conversation unless you are going to give them a CAGE questionnaire or a MAST, an M-A-S-T, Michigan MAST exam. And I think this should be part of your intake procedure. So when you look at the patient for the first time, if they answered some of those questions in the affirmative, then you can have the conversation with them. And I hope that answers the question. But that's, unless you do the screening, you're not going to be able to have that conversation.
And are both of those questionnaires available? I know the cage is that you could just Google and print it out, but is the Michigan Mask also available online?
Yes, yes, it should be the mask. They even have a modified mask, I think, that is available. Okay, continuing with treatment, as I said, it's behavioral, detoxification, cognitive insight, emotional understanding, and transformational experience. Treatment and recovery take time, and I think this is something that is very important. The transformational experience is an outgrowth of emotional work, and it takes about a minimum of 6 months for any cognitive changes to occur. So it's a lot of emotional work. It requires processing by professionals. You have to deal with denial or lack of insight, defense mechanisms, shame and feelings. And remember that most people drink and use drugs to cover feelings. Addiction is a disease of feelings, because in the day-to-day world, people don't think about feelings. They think about how you look, not about how you feel. So it's a significant impact for people to get in touch with feelings. Childhood and adult losses and pain are timeless, and therefore intermingle with the pain of active addictions and must be teased out. Treatment teaches one how to process and integrate issues, and then supports and guides one through the work. So treatment is hard work. And a lot of people that are not successful in treatment is because they don't want to work hard. They don't want to do what it takes to get well. Now, HMO, this is just a slide to show you that in our business, the HMOs have busted addiction because they don't allow us to treat it like it should be treated. Some people will take the approach to the single session therapy. And I think a lot of families do this. They say, why don't you just snap out of it? If you got a problem, just stop. Just put the drink down and don't pick it up. And as you can see, this gentleman is just sort of smacking the person. Punishment will never work, because you don't want to treat people with punishment. You want to be kind, respectful rather, and let them know that you are concerned about them, that they are not bad, they're not weak, but addiction is a disease just like hypertension, diabetes, or cancer for that matter. This is a slide just to show an MRI that shows the recovery of brain function. And in this slide, we're using methamphetamine. But the gist is to just show you, if you look on my left from the way I'm approaching the slide, you can see a healthy person's brain with all of the neurotransmitters and everything working. And in the middle picture is a meth abuser after they've been abstinent from meth for 1 month. And look on the right side, and you can see even after 14 months that the brain has not returned to normal. And with alcohol, it takes approximately 24 months for the brain to return to normal. And I think that's a huge issue to address with patients, especially if you have patients who have been in treatment and they return to your practice. You need to be able to let them know that it's going to take some time for the brain to come back to normal. Now, they may be feeling normal, but they are very susceptible to relapse during that period of time. The types of therapies we use: individual, group, and of course the milieu of the community, supportive, Insight-oriented is another approach. Some people use psychodynamics. We don't do a whole lot of that in treatment these days. But the major thrust of treatment for addiction is CBT, cognitive behavioral therapy. And as you know, cognitive behavioral therapy meaning I got to change the way I think. And that's what takes time. Family therapy is integral. If you don't treat the family, you might as well be peeing in the wind, which is, you're not going to do any good. And of course, the 12-step program and pharmacotherapy, we have several pharmacotherapy interventions that are very helpful in helping people avoid relapse. I will mention AA, the 12 steps. It's not just merely abstaining from the alcohol. They emphasize coping, adaptation to life, dealing with life on life's terms, recognition of feelings. The AA program discourages regression, acting out, avoidance of negative emotions. In other words, pain, and I tell patients all the time, without pain there can be no gain. We think about it when we go to the gym, it's the same thing. If you don't hurt, you can't heal. And I think a lot of people drink and use drugs and other acting out behaviors to avoid dealing with pain. The 12-step program reinforces self-care skills such as anticipation of consequences, curbing of impulses, limit setting, and showing up of boundaries. And I think boundaries are very, very significant. It also encourages the development of frustration tolerance, patience, impulse control, and affect regulation. Affect regulation is a very important aspect of treating addiction. Now, the 12 steps, as you can see here, are illustrated. Steps 2, 3, 8, 9, and 11 have to deal with relationships. Relationship with self, the higher power, the sponsor, other alcoholics or colleagues, home group, the template for family and friends. Step 4, 5, 6, and 10 deal with self-examination. And in the 12-step program, they call that cleaning house. Look at your character defects. Look in that mirror. See the things that you don't like about yourself and go on to accept them. Steps 8 and 9 deals with making amends and asking for forgiveness or forgiving others. And step 12 is helping others. Once that person has reached the 11th step, then the 12th step is all about giving back and helping other people who suffer from addiction. The prognosis, critical factors in recovery. If a patient has a psychiatric comorbidity, i.e. depression, bipolar disorder, schizophrenia, or anxiety, all these have to be addressed. If they are not addressed, then the chances for relapse are significant. Also, family support, caring confrontation, not attacking the patient as if they are the enemy, but showing them that you care about them. The family must show them that they love them. And if you're a family physician, I know when I was in family practice, we were trained in doing family meetings with families all the time. So bring the family in. Let them know that the patient doesn't need to be attacked as if they were bad or weak, but they need to be shown love, but still expect them to be responsible. No walking on eggshells. Spouse and loved ones usually feel left out. Bring them in. Let the patient know that it's a family disease and that their behavior has impacted the family directly and indirectly, and the family needs to be treated as well. And there must be a reestablishment of trust. Employment issues have to be addressed, time in treatment, and aftercare. people who participate in aftercare for 1 year, the success rate is about 85% that they will be abstinent for 5 years. Medications, as I mentioned, they help facilitate recovery, and these medications are for alcohol, Campril, naltrexone, and the new kid on the block, which is Vivitrol, which is injectable naltrexone, Antabuse is an aversion drug that we use. It doesn't do anything for cravings, but if they drink on Antabuse, some people will get very ill, and there have even been deaths that have been reported. Now, buprenorphine, I'm going to mention that because some of you guys may be waiver physicians that you can treat narcotics in your office, and that's where we use buprenorphine, Suboxone, or Subutex, and psychiatric medications also, antidepressants, mood stabilizers, atypical antipsychotics, anxiolytics, and other drugs. And Chantix is for smoking cessation.
Dr.
Medications
Richardson.
used to treat drug addiction, and as I said, we're going to mainly look at alcohol, but if there are questions about other things, we can answer them at the end. Alcohol and drug addiction, mainly we're going to look at naltrexone. Naltrexone works for both narcotic and alcohol. Disulfiram, which is the generic name for Antabuse, is good for relapse alcohol as well as cocaine and other drugs of abuse. Camprosate, which is Campril, helps prevent relapse, especially to alcohol issues. Now, the reason these medications are significant, if you do not use medication, 50% of alcoholics will relapse in 2 weeks. If they've had 3 to 4 detoxes, 70% will relapse in 2 weeks. We recommend treatment for 1 year, especially in patients with a family history of addiction, with a relapse history, or cravings. These are all patients that are at high risk for returning to drug use, and medications are almost mandatory if you want to help them. And Chantix, as I mentioned previously, is for nicotine. It's very effective, but it has a lot of side effects, and we can talk about some of those in the question and answer period if people have questions. The subtypes of alcohol dependence, I think, is important for primary care physicians to know. You look at type 1, and this is a late onset. Usually the disease starts after 25 years of age. There are few familiar alcohol dependency antecedents, slower disease progression. It's a milder form of alcohol dependence. There's a very important environmental influence, and these patients will have minimal criminality. If you look at subtype 2, this is an early onset of alcohol-related problems. Usually the patients are less than 25 years of age when they start drinking. There's a high paternal type 2 alcohol dependence history. It's a more severe form of alcohol dependence. Little environmental influence. A lot of this comes from genetics as opposed to the environment. There's frequent criminality, and there's a more frequent presence of personality disorders in this group of patients. To sum up treatment, what is treatment? Treatment is pharmacology, cognitive behavioral therapy, psychoeducational, 12-step and spiritual, experiential treatment, and contingency contracting. All of these have a place in treating the addicted patient. And this is the ASAM placement criteria. I don't think this is appropriate, so we're going to move over that. But I want everyone to remember that addiction is a primary disease. It's a neurobiological disease. It has a genetic component of vulnerability, but it is usually precipitated by stress. And I think that's a very important thing to remember. It's a psychosocial, environmental component. It is developmental, and manifestations are influenced by the interplay of biology and environment. These are the 5 C's. I mentioned 3 of them when we started. The first C is loss of control, consequences of use, continued use in spite of consequences, cravings, and compulsive use. And this is just a normal dopamine release in the from the presynaptic nerve. This is hampered by drugs like alcohol, especially cocaine, methamphetamine, and some of the new drugs that are out now that you guys will be seeing, bath salts and spice, which people can just go into any head shop and purchase. The brain reward pathways, sort of to reiterate an earlier slide, the midbrain is what drives all addictions. It's what we call the pleasure center, including the nucleus accumbens, the amygdala, the ventral tegmental area, and the prefrontal cortex. It's not only important in drug dependency, but also in essential physiological behaviors such as eating, drinking, sleeping, and sex. So the midbrain is where the action is. Cravings, obsessive, intrusive, ego dystonic, romancing, and it's a neurophysiological event. It's a memory condition cued, as you saw on the MRI with the cocaine video. It has emotional base, positive or negative, and cravings can be overt or covert. Thank you for attending this event. And if there are any questions, I will be glad to attempt to answer them at this time.
Well, we do have a few. I'm not sure if you can see them in the queue, but one is, how do you bring the family in? For instance, do you have to have the patient's permission? Like, is there a confidentiality issue? And is there a billing for an encounter with the family members?
I see a question about confidentiality. Billing for encounter with family members.
I think that was a part of the first question.
Yes, well, as you know, HIPAA and confidentiality, the patient has to give permission for you to contact the family, obviously. I don't know how you have your CPT code set up, but in our office, we have codes for family interventions or family meetings, family education. And I think that there are codes if you sort of look at the ICD 9 with the CPT codes. I think you can find codes that would probably be billable depending on the carrier. And I know that's difficult these days because some of the carriers they don't want to pay for anything. But I think if you work with a social worker or someone in your office that could look up some codes, I think there are billable codes especially for family physicians.
And then there is another question. How does your
Another question says, how do you manage options change for pediatric patients? How do your management options change for pediatric patients? Well, I treat a lot of adolescents, and I think that would probably fall into the pediatric realm. And most of the time, the adolescents are brought in because of behavior problems. And I must say that my office is primarily addiction. So when parents call me or bring their kids in to see me, and I see kids from 13 up, it's usually because there's a problem. And I must admit that most of the patients I see for the first time are either in the hospital or they come into our facility for an evaluation with the parents. So the treatment options are basically going to be the same as far as, bringing them in, doing a triage. They won't need as much from a detox standpoint.
Are you able to see?
And Sabrina, if you can see those questions and if you can read them out, I'm having a little difficulty viewing them on. Okay, now I can see them a little better.
Okay.
Do you find naltrexone and Campbell better for alcohol treatment, or are there rules of thumb to use one versus the other? I'm having a little difficulty reading this screen, and it might be due to my bifocals. Okay.
Yes, I can read them for you. Can you hear me? Okay.
I like naltrexone. I think I like naltrexone because it's only one pill, so it's more convenient. With Campbell, you got to give the patients 2 pills 3 times a day. And I don't know about you guys, but I have trouble getting people to take medication 3 times a day. So that's one of the, and I think the efficacy, in my opinion, with naltrexone is a little bit superior to Campbell. I have used both, but I'm more of a fan of naltrexone.
Dr. Richardson, can you hear me now? Dr. Richardson?
Are there any more questions?
I have one. Are you able to hear me?
I have no sound here at all, if anybody can hear me.
For the audience, I guess we're having some technical difficulties. So if you guys can hang on just 1 second. Dr. Richardson?
Yes.
Okay. I do have a question. Are there any treatment options for patients who are uninsured? Like with your office, you obviously have a private practice, but many of our clinicians are dealing with clients who are uninsured or underinsured.
Okay. Treatment options for the uninsured. That is a difficult question, but I will say that all counties, especially in Georgia, there are mental health and substance abuse um, organizations affiliated with in every county.
Mm-hmm.
So say, for instance, in Fulton County, there's Fulton County Alcohol and Drugs and Mental Health, and they are obligated to triage, evaluate, and treat patients who have addictions. So I think that that would be my recommendation. And also, there are some programs that get grants. Say, for instance, if you have, and I'm not trying to plug anything, but say if you have a female who is pregnant or a female who has HIV positivity, or they have children and they have addiction problems, there's a program called Mary Hall Freedom House that is located in Sandy Springs if you're in the Atlanta area, and they take patients from all over the state, all over the country actually, and they can get grants for patients to come in for treatment. So there are some ways for people who are uninsured to access the treatment process. But I must add that it's not as ubiquitous as it should be, in my opinion.
And is the standard of care, just as you mentioned, where they get treatment for their addictions that could include medication and or detoxing?
Yeah, some question here. I'm looking at a question here. It says about affect regulation, and what affect regulation really means is whether or not a person is able to regulate their temperament, whether their impulses are under control. You know, whether people, if you say something to them, they will cuss you out or throw things at you or want to fight. So affect regulation is being able to regulate the mood on a self-containment level.
Well, we will take one or two more questions if we have them. Dr. Richardson, were you able to hear my last question?
Is she talking?
Well, I think his audio has gone out. So I would like to say to our audience that I appreciate your participation. Thank you for presenting such an engaging and insightful presentation tonight, Dr. Richardson. And thanks again to our audience for taking the time to be with us. Your comments and questions have helped to make this an enjoyable experience for all of us. I would also be remiss if I were not to say thank you to our tech team, Qualin, tonight, who actually was not feeling well today, but pushed through just to be here. So thank you very much. An evaluation for this webinar will pop up in another window if you're using Internet Explorer, or another tab if you're using Firefox. So please take the time to complete the evaluation. The CME questions will be tied to it for your CE credits, as well as we would like to have your feedback. Please join us again for an intriguing and free CE presentation on August 17th entitled Diagnosing and Treatment of Pulpal versus Periodontal Disease. The webinar that we had scheduled for next Wednesday, the 10th, has been rescheduled for September 7th. So our very next webinar again will be August 17th at 8 Eastern Time. Again, this series is made possible through a partnership between the National Center for Primary Care, the ACU, the National Healthcare for the Homeless Council, CDN, and Migrant Clinicians Network. This partnership allows PrimaryCareForAll.org to serve as a resource for the National Health Service Corps members. Thank you again, and please enjoy the rest of your evening.